Corel has authored and co-authored over 500 journal articles. He has served on several expert consensus panels on the use of antipsychotics across a range of psychiatric disorders. He is a reviewer of over 70 peer-reviewed journals and an editorial board member of 12 scientific journals. Professor Corel is the principal investigator of the steering committee of several large, federally funded grants. He has received over 40 national and international research awards and fellowships. Since 2014, the year of inception of the metric, he has been listed by the Thomson Reuters as one of the most influential scientific minds and the top 1% scientist in the area of psychiatry.
Right.
It is a real pleasure to introduce Professor Christophe Corel, who will be talking to us about optimizing outcomes in the treatment of schizophrenia, the role of long-acting injectable antipsychotics. Professor Corel.
Thank you so much for the very kind introduction, and thank you for being here. It's my first time in Egypt, and I've been greeted so well already. You're such a hospitable country, and it's wonderful to be at this Pan-Arab meeting where many people and minds come together trying to obtain the knowledge to further the treatment and outcomes of our patients. In schizophrenia, as in almost all psychiatric disorders, long-term care is most important. And that's what I will be talking to you about today. This is my disclosure information. And this is what I would like to cover with you. What's the efficacy situation in schizophrenia? Where do long-acting injectable medications fit? Is there an earlier use that we should consider? And what are the side effects and how to offer these treatments? This is from a study that we published a while ago, about 3 years ago, where we looked at short and long-term outcomes of patients with schizophrenia. In black, you can see the chronic schizophrenia outcomes, and in red, you see the first episode's schizophrenia outcomes. Do you have a pointer? No. All right. So you can see when patients are treated by us, there's often an exacerbated acute state, and what we want is a response, a reduction in symptoms. And with the currently available treatments, 1 in 5 to 2 out of 3 patients will be responders. In first episode, actually 40 to 90% will respond. So whatever we give early works pretty well, but it has to be something that people can continue to take. But a response is a relative outcome. People may be better, but not well. For wellness, we need an absolute threshold, and that is called remission. Since 2005, this is defined as a 6-month period of no more than mild positive and mild negative symptoms. And there we already run into trouble. Less than half of our chronic patients will be stable with no more than mild symptoms for at least 6 months. Yes, first episode patients do better, but the lower bound of 17% already becomes somewhat problematic. But even remission is a symptom-based approach, and I hope that you and I became interested in mental health to treat people and not just symptoms. So for people, we need not just symptom control for a year or 2, but we also want functionality. Adequate self-care, food, shelter, hygiene, at least one psychosocial contact outside of the family per week, and something meaningful to do. 1, 2, 3 days of unpaid, even voluntary work. And that's put together for a year or 2, symptom stability, functionality, is called recovery. And that's where we still fail our patients. Around 13.5% of patients only will be in recovery, 1 or 2 years. And even though first episode patients respond and remit better, their recovery rates are not different. So where do we get lost on the road to recovery? What is the block? So the authors of the meta-analysis we took the recovery rates from asked the question, maybe we want too much by having all the symptoms and functionality improved? How about we just want symptomatic recovery? Wouldn't that be easier to give us a higher number of recovery? And actually the answer is no. There was no difference whether you wanted 1 or 2 years of symptom stability without functional requirement, or you added the functional requirement. And that tells us what the road to recovery, what the block is what you and I fight with and struggle with every day, and that's relapse. Patients just don't stay stable for long enough so that we can rehabilitate them, that they can get reintegrated into the usual life. So, and why is that? What's the biggest predictable factor for relapse? It is not taking the medication. So the medication works in the beginning and then we lose the gains because people relapse. So on the right top corner, you see the relapse rates from placebo-controlled discontinuation studies. So patients are stabilized on a medication and then they either continue or double-blindly they go to nothing. And that's what our patients often do without our knowing. And then you can see that within 3 months, 1 out of 3 patients worsen off the medication. Within 6, 50%. Within 9 to 12 months, 2/3. And after 1 to 3 years, 80% will have relapsed. And even in first episode, that's the red color, you can see that in a study that we conducted at Hillside Hospital, lots of research money, a nice team, psychosocial support, still after 5 years, 80% relapse once, 78% twice, 84% 3 times. And what was the #1 predictor of relapse? We looked at imaging, cognition, neurodevelopmental pathway, side effects. One single simple factor explained 500% increase of relapse, not taking the medication. So we need to keep the relapse down because it erodes patients' lives. It makes them self-stigmatize, oh, I'm a chronic patient. People withdraw from the patient, but also the brains of patients change. After each relapse, about 1 in 6 to 1 in 7 patients will not respond as well anymore. So we breed, in the top left corner, secondary treatment resistance. In first episode samples, 5 to 10% of people only are treatment resistant. But after relapse and relapse, the brain is a learning machine. Whether you learn playing golf or tennis, learning a new language, you get better at it. The brain gets better at being depressed, psychotic, and anxious. So, after years, we have now 30 to 40% relapse prevention. So that tells us that the #1 goal in the maintenance long-term care of our patients is not the acute stabilization. That's just the beginning of the road. We need to keep them stable. So what is the efficacy of medications then? Well, this is from a network meta-analysis, and you can see that overall, medications are relatively good, efficacious for schizophrenia with a median effect size of maybe 0.4, 0.5. That's a moderate effect size. Now, the older medications generally look a little better than the newer medications because placebo response has increased. But the one medication that is, even though it was studied 10, 15 years later, equally efficacious as previously studied medications is paliperidone, very close to risperidone. So it's a very effective treatment that is not affected by placebo effect a lot. But in the long-term treatment, if we want to see what predicts poor outcome, I want to show you the right-hand side factors, and these are modifiable risk factors that are actionable, where we can change the trajectory. One is longer duration of untreated psychosis. Psychosis is not good for the brain. So get people into care earlier. Reduce stigma. Treat them as early and diagnose them as early as possible. Comorbidities. Treat comorbidities. because patients often don't only have schizophrenia. And addiction is one of them that predicts poor outcome. And addiction is also related to poor adherence. Then early non-response. If you see nothing that meets the clinical eye after good dosing of a medication for at least 2 to 3 weeks, most likely you need to move on, because in that patient, this medication may not work. But the biggest risk factor and the most addressable one is non-adherence, which is related to relapse. The more relapses people have, the poorer the outcome. And we can use medications that we prescribe and we don't know whether they're taken, or we can use long-acting treatments that actually make visible the non-adherence. So a long-acting treatment is not just a treatment tool, it's also an informational tool. It's the only way that you know the month, the week, the day, the hour a patient stops their medication. And then you can do something about it. That's very important. How often have you added another medication, increased the dose, switched, because you thought, oh, the illness is so bad and so strong, but it was actually the behavior of the patient not taking the medication. So we published a paper in June in World Psychiatry summarizing the arguments for maintenance treatment in schizophrenia, long-term. There were 9 commentaries woven around this paper, commenting on whether they agreed or disagreed. And these were some of our main arguments. We need to keep people on maintenance treatment that's effective and continuous, because long-term symptoms predict poor outcome, predict increased suicide, predict decreased treatment response, and even progressive brain functioning and also volumetric decline. With each relapse, people lose gray matter. You have less brain to rehabilitate. You have less of a patient's cognition to reintegrate them. So we need to put the best foot forward early in order to not lose patients' motivation, social context, but also biology. And obviously, the longer the treatment is ineffective, the greater the poor outcomes also for health resources, for a country, for a family, and also there's a lot of burden individually. So how well do we do by continuing antipsychotics versus stopping? This is from a maintenance meta-analysis where the number needed to treat was 3 for continuation versus discontinuation of stabilized patients. That is an enormous, enormous number needed to treat. Statins, aspirin, to prevent one cardiovascular event, 10-fold lower number needed to treat. 40 to 45 people need to be treated to prevent one further event. Mammography versus manual palpation of the breast to pick up one more breast cancer, 100-fold lower effect size. 350 to 450 women need to undergo measurement with mammography to pick up one more breast cancer. We still do these things because the outcome is grave, but with a number needed to 3 for preventing schizophrenia, we need to continue. But we need to continue with agents that we know are in the system and are effective. But obviously, having people stable doesn't give them a job. Here, continuation with an antipsychotic or having placebo had no difference in employment, because we need to use the stability to then rehabilitate patients. And obviously, medications have more side effects than placebo. But our drugs differ based on how much of an impact a medication has on sedation, on weight gain, 2 of the biggest risk factors for treatment discontinuation, and poor quality of life. And when a patient has poor quality of life, why would they want to continue the treatment? So when you ask family members and patients, sedation and weight gain are number 1 and 2, and also cognitive fuzziness, that they can't think straight. That's what patients don't like. They feel altered. But in this meta-analysis, there was one interesting sub-finding, and that was the longer the studies lasted, the less the effect against placebo. So the lower you go, the stronger the effect against placebo. You have a reduction in risk of relapse. But the longer that studies lasted, less effect. What's happening? Do our medications get sick themselves? Do they get stale and weak? What do you think is happening? Long treatment, less effect. Well, as you know, if we want to do things daily and daily, it's not easy to do, even for us, to keep us getting. But people who are mentally ill, have cognitive problems, maybe lack of insight and support, over time, even in these studies, they may not take the medication as prescribed. And that this is true as the reason you can see here, because the reduction in relapse was significantly greater versus placebo in people who were randomized to an LAI, long-acting injectable, versus people on oral treatment. So that brings me to the question, what is the role and what are the efficacy signals of long-acting treatments? So this is from a paper we published 2 years ago, where we, in 24 pages, that's a long paper, tried to summarize everything we know about long-acting treatments. And table 1 has the different long-acting treatments that we have available in the United States. 2 first-generation agents, fluphenazine and haloperidol. You may have more, sucralfate, fluphenazine, but the principle is the same. Or the atypicals, first risperidone, Consta, then paliperidone palmitate, and aripiprazole, which I think is only approved in some Arab countries. And what's the difference between these agents? So on the second column, you see the first generation agents are all oil-based. The second generation long-acting treatments are all water-based. But why would a whole generation of medications have changed the delivery system? Well, our cells in the body contain much more water than oil. So if you bring an oily substance into water, it bulges the cell and there's more pain. So what we've achieved with the newer agents is less pain upon injection and less injection reaction. There are other differences in terms of dosing interval. Fluphenazine every 2 weeks, some doses of olanzapine every 2 weeks, and risperidone Consta every 2 weeks. Monthly injection with haloperidol, with some doses of olanzapine, one formulation of paliperidone, and also aripiprazole. And then we have now, and I'll go more into detail about that, even a 3-monthly injectable long-acting treatment with paliperidone. That is seasonal treatment, spring, summer, fall, and winter. Instead of 365 times a year, wavering, should I not take, should I take your drug or my drug? Ambivalence is part of the core symptoms of schizophrenia according to Boiler. We believe that is true. Instead of that, you have just 4 decision points and people are on their way. Another difference is, do you need to rely on oral co-treatment during the transition from oral to LAI treatment? You need to do that with risperidone Consta, 3 weeks. You need to do that with the aripiprazole formulations, 2 to 3 weeks. But there is a booster injection with paliperidone, day 1, day 8, and then you do it every month. And that way you spare the patient the oral phase where you're not sure whether they're taking it. Do you know why you have to start in the deltoid with paliperidone and not in the gluteal muscle? What's the difference between deltoid and gluteal? Rapid absorption, exactly. It's a smaller compartment and you get quicker high levels. So you want to get to therapeutic levels. But the half-life is shorter. So if you need high levels, you go here. But if you know that after 3 weeks, maybe some of the effect is going down long term, you want to go gluteal because you have a longer half-life. Yeah? Okay, in general, we would expect that long-acting treatments have less side effects than oral treatments because you have less peak-trough variation. You have a smoother area under the curve. But there's one side effect that's unique to an LAT, only one of them, that has a higher side effect rate. And that is olanzapine palmate, which can have the post-injection somnolence, sedation coma syndrome. Why? Because it is highly water and blood soluble, and during the injection, even when you aspirate and you don't get any blood, and you inject, there might be a laceration of a blood vessel, and then a lot of the medication designed for 2 or 4 weeks can enter the bloodstream, and people can be over-sedated. That only happens with olanzapine palmate, not any other drug, and that's why people have to be monitored for at least 3 hours after each injection. And many patients after the second or third injection say, leave me alone, and walk out, and that can be dangerous. So we have to monitor them. And it's not an allergic reaction, it's a mechanical problem that basically the drug can enter the bloodstream. So here you see the pain ratings in green with the first generation agents. That's out of 100. I usually do it out of 10, so you can see it's a 2 to 5 out of 10 pain rating, whereas with the atypicals, it's a 0.5 to 1 out of 10 points. So it has reduced the pain ratings. How well do the LAIs do against placebo in relapse prevention? Here you see again the number needed to treat. It's 4 to 5 after each 4th to 5th patient on an LAT versus withdrawing it and being on placebo. You prevent 1 more relapse. But obviously in clinical care we don't decide, well, do I give you placebo or do I give you an antipsychotic? We decide, do I give you an oral agent or do I prescribe an LAT? So the first meta-analysis that compared these two, oral versus LAT, in randomized trials, showed that yes, LATs are better. But then we repeated this meta-analysis, not having 1,700 patients, but 5,000 patients, and to our big surprise, we're unable to find advantages of the LAT versus oral treatment in relapse prevention, up on the top, and in all-cause discontinuation. And we scratched our head and said, this doesn't make sense. Clinically, we would expect better outcomes with the LAT, but we don't find it. So we wrote to the editors and in our paper, okay, here are the results, but don't believe them. Don't use them for your guidelines. And obviously, the reviewers and the editors said, are you kidding me? Rejected our paper 3 times. You're a world-class psychoanalytic, yeah, maybe 2. A world-class pharmacologic group and meta-analytic group, and you're using the gold standard of medicine, an RCT. Why would we not believe your data? Come on. So what do you think? What did we write in the letter to the editor and in the paper? Why are these data difficult to interpret? Well, who are these patients who get into an RCT? They say, Dr. Corral, please enroll me in a double-blind placebo-controlled trial. I know I have the illness, I want the injection here with medication or here with a saline, or I get medication, you give it into my hands. I want all your young research coordinators go around me and give me $50 and some coffee. Here I am. Well, how many of your patients are like that? Not too many. So we propose that maybe the patients in the RCTs are not as sick and are more compliant. And actually, they know that their compliance will be measured. So when we looked at compliance rates in the RCTs, there was no difference between oral and LAI. Well, if they're taking it, if they're really taking it, then you don't need an LAI. But is this the real world patient? So this was published 2014. So our next thought was, maybe this is not the right type of study to ask the question, is an LAI better than an oral? So what do we do in clinical care? Do I give one patient one treatment and the other patient another, and then I compare who's doing better? That's not how we judge our efficacy. We have one patient, we see how they're doing before, we make a change, and then we evaluate within the same patient, is the patient getting better or worse? Do we have studies like that? Yes, we have. And these are called mirror image studies. So patients who are not doing so well, where the clinician feels something needs to change, something changes, the LAT is given, and then we see how they're doing afterwards. So here we had 25 studies, 6,000 patients, and the result was overwhelmingly positive. Even without meta-analytic pooling and acrobatics, 23 of the 25 studies asked this question and answered it the same way. The LAI phase in the same patient with the same genetics, the same help system, the same insight level, nothing has changed. Only the prescription of oral to LAI has changed. After the change, the outcome was dramatically better. So there was a 60% decreased risk of hospitalization in the same patient after switching to an LAI, and for multiple hospitalizations, the effect was even better. So the revolving door patients benefited even more. And then we did a final meta-analysis, not of 5,000 patients, but of almost 100,000 patients, 91,000 to be exact, 41 trials, and these are cohort studies where clinicians choose, well, do I give an oral or do I give an LAI? And even there, where there's a bias, who gets the LAI? These are the sicker patients, the ones that are more at risk for relapse. Despite that, the LAI beats the oral treatment. And here you can see that patients who got LAIs were sicker, more chronic, had more hospitalizations. Despite that, they beat the oral. So we can't deny these data, and I think should continue taking them into account. But what about high-risk populations? One is people who have problems with the law, people who have substance abuse, usually excluded from studies. Here is a very brave study that Janssen did, comparing paliperidone, palmitate once monthly, versus any oral treatment that could be optimized. So it favors a little bit, you can choose among many drugs versus having to take one. But despite that, paliperidone beat the oral paradigm in these high-risk patients, now in an RCT. But an RCT is one thing, real world is another. But what about after patients stop? They stop oral treatment, they even stop an LAI. So let's compare the outcome after stopping treatment and evaluate, is there a larger window of opportunity when an LAI is stopped? So here you have the placebo arm of 3 different trials. So it's not the same trial. The lower black line is when patients have been stabilized on oral paliperidone and went to placebo. The question is, how long does it take until 50% have had an exacerbation or relapse? And you can see after 2 months, 50% got worse, oral discontinuation. The green line is they've been stabilized on once monthly injectable paliperidone. It stops, and it actually takes 172 days, that's about 7 months, until 50% have relapsed. But then on top, the blue line, is patients who have been stabilized and had at least 1 3-month injection. And for them, it takes more than a year until 50% relapse. So we have, even when they drop out of care, and we know because they don't come back, we have a larger window of opportunity to call the families, have an outreach team, get them back into care without relapse. So what about then the 3-monthly, which seems even after stopping to have such an advantage over the oral and the once monthly? Even the carryover is better. So what is paliperidone 3-monthly? Well, you have to have treated the patient first on the once monthly for at least 4 months. That's 5 injections because you have the booster at 1 week. So at least 4 months of of once monthly. And the last 2 injections have to be the same dose so that you're sure the patient tolerates it and it works. I usually try to make it 6 months just to be certain, because then I want them just on the 3-monthly treatment. How do you translate the dosages? Well, here you see you have to basically multiply the once monthly by 3.5. Yeah, it's a very simple, I don't know whether in your countries you have the European or the US, but the 100 milligrams in the US would translate into 350. You see that there's also a slight increase in the milliliters, but it's not too much and it's well tolerated. So here you see the pharmacokinetics in black of the once monthly with a 95% confidence interval. And then after the 4 months, it either stays once monthly, if that's the white line, or you go to the 3 monthly, and you can see it's basically an overlap. The 3 monthly injection covers the patient as well, pharmacokinetically, as the once monthly would. Very important though, because there are all these molecules for 3 months that are released at different time points. You must shake the vial very vigorously for 15 seconds. And 15 seconds may be longer than you believe. So it's good to actually look at your watch and not just shake like this, but shake up and down. Because you want to have a very nice emulsion that goes into a patient's system. So still not 15 seconds, still not 15 seconds. Okay. We have 2 different needles in the pen,